Oh, I forgot that I need to record. Thank you, Noon. I appreciate it. So this is recording now. Um, if you're dialing via telephone, Google Meet has muted you. If you need to speak to the group, please press star 6 on your phone to unmute and mute. We kindly ask that only those who are speaking to the group unmute their devices via Google Meet. DUR board members reserve questions until the end of presentations or ask in the Google Meet chat. For those providing public comment, if you would like to provide public comment, a conflict of interest form must be on file. Please send an email to medicatepharmacy@utah.gov. Attendees that are not members of the DUR board, please enter your contact information in the Google Meet chat or send an email to medicatepharmacy@utah.gov. Please use the chat on the right if needed. And please provide normative feedback after the meeting to help us improve our process moving forward. And thank you. All right. Per the agenda, welcome everyone. And the first order of business, excuse me, is the review and approval of minutes. And so can I get a motion to approve the minutes from the October meeting?
So moved.
Thank you, Dr. Smith.
Second.
Thank you, Dr. Brinton. All right. And all in favor?
Aye.
Thank you. Any opposed or any abstentions? All right, thank you. Motion passes to approve the October DUR meeting minutes. And for housekeeping, I just have one item. Is Mr. Cordero Baxter here today? All right, so just so everyone knows, Mr. Baxter, he was accepted to serve in the DUR board as our consumer representative, and he was set to start the meeting of September 11th, but unfortunately he has not been able to join any meetings thus far. And this is the third meeting, and per the bylaws, if a DUR board member misses 3 consecutive meetings, then that's grounds for dismissal. And so I need to look into it and see if I can try to contact him. I haven't been able to, so hopefully everything's okay with him. But that's all I have for in terms of the housekeeping item for today. And I see that Dr. Weinstein is here today. Good morning, Dr. Weinstein.
Good morning.
All right, so we just got through the housekeeping item.
Yes.
And now I'll go on to the prior authorization updates. And so yeah, we were able to finalize criteria for Omnipod 5 and also the Sivaskin for RDEB and Himpavci for hemophilia. The Sivaskin and Himpavci PA have been posted at our Medicaid website, and the Omnipod 5 PA, I believe that one will start coverage in January. Is that right, Noon?
Yes.
Yes, and so we'll post it in January. But yeah, that's it for the prior authorization updates. And I'll turn the time over to Dr. Weinstein to continue with the agenda items, please.
Thank you very much. And I apologize for my brief delay. It looks like first we'll have some public comments. Is that correct? From
Yes.
Dr. Miley? I'm saying that correct? If that individual is here.
Yes, Dr. Weinstein, and I will take care of the timer set for 3 minutes.
Sorry, I'm having a little technical difficulty where I can't see my screens, so I'll keep fiddling with it. But if that individual is not responding, do we see a comment?
I thought I saw them join the meeting. Dr. Miley, are you here? Okay, he's raising his hand.
Very good.
Good morning. Can you hear me?
Yes.
I apologize. I had to adjust all my audio settings. So thank you for giving me just a moment to get set up here. Good morning again. My name is Dave Miley. I'm a pharmacist with Teva Medical Affairs. And I'd like to thank you again for the opportunity to provide just a few comments about Simlandi and Solarsdi, which are both biosimilar cytokine modulators. I'll just briefly remind the committee that Simlandi is an interchangeable biosimilar to Humira, approved for all the indications as the reference product, with the exception of pediatric ulcerative colitis, which is protected by exclusivity until February of 28. Simlandi is available in multiple strengths and presentations. Solarsdi is an interchangeable biosimilar to Stelara, approved for all the indications and presentations as the innovator. Or refer you to the respective PIs for additional information, including warning precautions and important safety information. Both Simlandi and Solarsdi were launched as low-priced alternatives to promote cost savings and affordability. With that said, I'd like to take a minute and advocate for expanded biosimilar access within the Utah Medicaid program. Currently, the PDL does not have any adalimumab biosimilar or any ustekinumab product branded or biosimilar listed as a preferred option. As you're aware, biosimilars are held to the same FDA standards of safety, purity, and potency as their reference biologics, and extensive clinical trial and real-world evidence consistently demonstrate no clinically meaningful differences in efficacy, safety, or immunogenicity. Yet, despite this robust evidence base, utilization remains limited, often due to formulary design and/or administrative hurdles rather than clinical concerns. In closing, I'd urge the committee to improve Utah's biosimilar access policies and respectfully request the committee to make Solarsdi and Simlandi available as a preferred treatment option to Utah Medicaid patients without onerous step edits or prior authorization requirements. Thank you. I'm happy to address any questions.
All right. Thank you, Dr. Miley, for speaking with us, providing that public comment. Dr. Weinstein, if it's okay with you, I'll go ahead and present on the Absola and Enbrel for the prior authorization criteria.
Yes, I apologize. I had a little break in my connection there again. Please proceed. Thank you.
Okay, no problem. No problem at all. All right, and I'm going to make this a little bit larger. And can everybody see the Absola and biosimilars criteria? All right.
Yes.
And thank you. And I would like to apologize to the board members. I was able to, for the Absola and biosimilars and all the immunomodular PAs that we'll be presenting today, these are going to be part of the new hybrid PDL in January starting next year. And so we had to strongly collaborate with the ACOs in terms of the criteria. And so that's why it took me a little longer to send out the updated criteria. But from the criteria that I sent out on Thursday, last Thursday, a week ago, the changes are being manifested here by the highlighted yellow criteria. And I'll point out what changed so you guys can better see the update. So for Absola and biosimilars, infliximab is the main molecule here. And so the first part one, it says which medication is being requested. Absola is the preferred, or other infliximab brand or biosimilar non-preferred, and for which part 3 would be required. Number 2, is the medication being prescribed by or in consultation with a provider specializing in the disease treatment? Number 3, does the patient have any of the following diagnoses as listed here? And the provider can just check off what they are. And then number 4, this is a new one that was added since last Thursday. Does the requested medication and diagnosis follow FDA approved age, dosing, monitoring, and contraindications? Yes or no? Number 5, does the provider attest that the patient is not taking concurrent treatment or will not be used in combination with other TNF inhibitor, biologic response modifier, or other biologic DMARDs, Janus kinase inhibitors, or phosphodiesterase 4 inhibitors, as verified by prescriber attestation, member medication fill history, or submitted documentation? And number 6, has the patient trial and failed demonstrated an intolerance to or has a contraindication to the preferred adalimumab? Okay, part 2, select and fill out applicable selections. So section 1, additional criteria for ankylosing spondylitis, or AS. All the following criteria must be met. Is the patient at least 18 years of age or older? And number 2 was modified. So for the rest of the PA criteria that we'll present today, one of the things that we modified for number 2 is, does the patient have a diagnosis of the indication demonstrated by description of baseline symptoms present in the chart notes? And so you'll see that we added, we wanted to know what the baseline was in terms of the condition so that we can compare it with the reauth criteria moving forward. Number 3, has the patient tried and failed, demonstrated intolerance to, or has contraindication to at least 2 different prescription strength nonsteroidal anti-inflammatory drugs at the maximally tolerated dose for at least 1 month each? And so this is different in the sense that we are requiring at least 2 different prescription strength NSAIDs per the guidelines for ankylosing spondylitis, and also for the duration is at least 1 month each. So that's a difference there. Section 2, additional criteria for Crohn's disease. All the following criteria must be met. Is the patient at least 6 years of age or older? Number 2, does the patient have a diagnosis of moderately to severely active Crohn's disease as confirmed by applicable testing such as diagnostic imaging, inflammatory biomarker, or disease activity scale, and supported by a description of baseline symptoms, labs present in the chart notes? Number 3, additional criteria for plaque psoriasis. All the following criteria must be met. Is a patient at least 18 years of age or older? Has a patient been diagnosed with moderate to severe plaque psoriasis involving greater than 3% body surface area? If less than 3% body surface or body is involved, is there scalp, palmar, foot, or groin involvement causing significant disability? And then for number 4, has the patient tried and failed at least one of the following medications for at least 3 months, or is contraindicated to all 3, methotrexate, cyclosporine, or acitretin therapy. Moving on to section 4, additional criteria for psoriatic arthritis. All the following criteria must be met. Is the patient at least 18 years of age or older? Does the patient have a diagnosis of active psoriatic arthritis demonstrated by description of baseline symptoms presented in the chart notes? Number 3, has the patient had an adequate trial and failure of at least one of the following disease-modifying antirheumatic drugs, DMARD, for at least 3 months, unless all are contraindicated: methotrexate, leflunomide, sulfasalazine, azathioprine. Section 5, additional criteria for rheumatoid arthritis, RA. All the following criteria must be met. Is the patient at least 18 years of age or older? Does the patient have a diagnosis of mildly severe active rheumatoid arthritis? Has the member had an adequate trial and failure of at least one DMARD for at least 3 months? And again, that's what aligning with the current guidelines for RA as a 3-month duration of the initially trialed medication, such as hydrochloroquine, leflunomide, methotrexate, sulfasalazine, or contraindication to all. Section 6, additional criteria for UC, ulcerative colitis. All the following criteria must be met. Is the patient at least 6 years of age or older? Number 2, does the patient have a diagnosis of mildly to severe active ulcerative colitis as confirmed by applicable testing such as diagnostic imaging, inflammatory biomarker, or disease activity scale, and supported by description of baseline symptoms labs present in the chart notes? Has the member had an adequate trial and failure of at least one of the following for at least 2 months, or has a contraindication to all: high dose oral 5-amino salicylic acid drug or topical 5-amino salicylic acid drug? Number 7, and this is what was added to all the PAs as well as a new section 7, regarding the other off-label or compendia use of FDA-approved drugs according additional criterion. And so there's a clinical documentation show an adequate trial and failure with at least one FDA-labeled and Medicaid preferred medication if applicable. And number 2, provider attests the requested drug is being used for a medically accepted indication that is supported by information from the appropriate compendia of current literature, including at least 1 major multi-site study or 3 smaller studies published in JAMA, NGEM, Lancet, or other peer-reviewed specialty medical journals within the most recent 5 years. Supporting documentation must be included. Compendia use must be recommended by generally accepted compendia, such as American Hospital Formulary Service, Drug Information, United States Pharmacopoeia Drug Information, and the Drug Dex Information System. Part 3, non-preferred criteria. Part 1 and Part 2 must also be met. For request of any non-preferred biosimilar other than the preferred above, has the patient tried the preferred infliximab products? And so that's all of the preferred products. And then the reauthorization criteria, has the provider submitted updated chart notes demonstrated positive clinical response? And so this is different because we actually want the provider to submit clinical chart notes in this case for the reauth criteria. Initial authorization up to 6 months, reauthorization up to 1 year. And then the warnings and serious side effects are listed in the notes section. And that is it for Absola and biosimilars. Any questions? Yes, Dr. Smith.
Smith.
Hi, I have a few things to bring up. Sorry, just pulling this up here. Okay, so I have a concerned about this approach when it comes to pediatrics, because pediatrics have a lot of these conditions, but in many cases, most cases, they're not going to have the FDA age approval for these medications, but that doesn't mean that they haven't been studied in, lower than the age group that the indication would indicate. So I guess I'm concerned that we're setting up some barriers for pediatric patients by, like, specifically item number 4, and then, like, say under the different disease states, those ages are based on what's in the labeling. Which on the surface makes sense, but does it create a barrier for people treating, pediatric Crohn's, pediatric plaque psoriasis, et cetera? Another concern that I had was that these alternative, tried and failed treatments listed are not often the preferred agent for pediatric patients, and some of them don't have a pediatric indication at all. So that doesn't make a whole lot of sense to me from a safety standpoint. The last point I want to make is about the off-label compendia. The list you have here, AHFS, USPDI, and DrugDex. AHFS is only available in print unless it is wrapped into other software drug compendia. USPDI is not produced anymore that I'm aware of. And then DrugDex is not a term used to describe the whole micromedics compendia. I would just change DrugDex to micromedics. And then these are also not pediatric complete drug references. I would add up-to-date LexiDrug pediatrics as an approved compendia. Sorry to throw all this at you.
No, I appreciate it. Thank you for that. Because yeah, we definitely don't want to create a barrier for the pediatric patients, as you mentioned. But we were more leaning towards if there's that situation where, yeah, there's no label indication for younger children, then the provider can still have a pathway of approval through this section number 7. And so in that case, then we need to work on making section number 7 better so that providers can actually give us what is on the pediatric recommendations, like you mentioned, the LexiDrug pediatric option there. But thank you. And Dr. Britton.
I was just going to say that section 7, what would you add to it? This is pretty standard off-label language that the ACOs support, and the compendia, it says such as. So if you wanted something added, it makes sense, but it's just examples there. So is there something specific you would add to the off-label for pediatrics to address your need for not, having to try and fail some of the medications that are listed for adults, or that would specifically help you on pediatrics?
Yeah, the one I listed, up-to-date LexiDrug pediatrics.
So adding that compendia would satisfy that.
Well, this is a tool for providers, right? And if they can't find these compendia, I don't see that that's going to be quite as helpful. I'd like to see some listed that are currently used. Otherwise, the list I wouldn't think would be that helpful.
So outside of the compendia, though, for off-label use, that's primarily how pediatric use of this drug would be reviewed. So let's say we have one of the indications above, but it's a pediatric patient that it's off label, I think the reviewer would go to section 7.
Mm-hmm.
And would that meet the need on reviewing that drug for that member?
I would like to hear from a pediatric provider on that one. I personally think that this sets up barriers just because of the strict age cutoffs, but
If I might jump in, if the intention is for those off-label uses on the age criteria, then we're in the first element there. It says, you know, above or below, you know, below, above 18, above 6. If the intention is there for the person who's completing this form to jump down to section 7, then I think we might just insert something there that says, if you are requesting off-label use, you know, go to section 7 or something. I mean, they'll find it eventually, but I don't think that's clear. And I was wondering that too. How would we get prompted to go to section 7? And if section 7 has all the resources that would be appropriate across the age categories, then I think maybe that would direct, it might make the form more usable without changing the specifics of it. I think Valerie had her hand up, and Dr. Brinton has her hand up again too. So that was my thought about that, just logistic part of the form. Dr. Brinton?
Hey, Valerie beat me. Yeah. So when I looked at this earlier, I felt that it covered. I felt that section below section 6, the off-label use, was very flexible. But I really appreciate the insights that having specific things in there might be more helpful, like having the direction to go there, adding down, you know, the supporting documentation that talks about the different compendia. It says such as, so it doesn't say it has to just be those ones, but I think adding that in for lexicomp is a great idea. Just to be clear, I think anytime we can be a little more clear, it's probably very helpful. So I appreciate you guys noticing that. Like I said, I feel like the language right now would work, but it might be a little more opaque how it works, and adding those improvements that you guys both mentioned about, hey, referring down to here, and also let's get the lexicon on there as an example. Though again, it's a such as. I'm grateful that at least on the form I'm seeing, it says such as. It doesn't say it has to be these specific formularies. But I think that would just make things a little clearer. That'd be helpful.
Oh, can I mention something?
Valerie, please.
Oh yeah, I just wanted to mention over the years, like going through these drug compendia, I've noticed that something that's listed as off-label in lexicon may or may not be in micromedics and vice versa. So not always do you have congruence across the drug compendia, which I thought is very interesting. And then I've also come, like one of them will mark which off-label use is actually supported by a guideline. And I've noticed too through the years, like even I'll find an off-label use supported by a guideline recommendation. And even then, even with studies and a guideline recommendation, it won't be listed in lexicomp or micromedics. So I don't know at all if you want to consider also guidelines too. You know, since the compendia may or may not include a graded recommendation by a guideline that has reviewed the literature. And then one more thing I noticed is the clinical studies published in the most recent 5 years. Like to me, that's really restrictive, and any maybe off-label use, you know, it might take many years, 10 years or longer to accumulate the evidence to get to the point of being a guideline recommended off-label, you know, medication. So to me, the 5 years is a little bit arbitrary, but that's all. Thank you.
Dr. Britton.
To just guidelines, I think that would be perfectly appropriate to add to that section. As far as the latest 5 years, that's pretty standard off-label language to make sure that the literature is current. And if something is greater than 5 years and is effective, you would think that it is now in guidelines or in other labeling, things like that. So that's why the 5 years, it's not particularly arbitrary. It's just to make sure that the literature is current and isn't based on some, old guideline or old thinking on a disease state.
I imagine it would be a rare occurrence that somebody would pull out a remote reference that's been lost somewhere in clinical practice and try to justify treatment. So, I might or might not include the 5 years, but if that's standard, I don't think that's prohibitive. Dr. Smith?
Muted. I'm not sure this always applies to pediatrics, for example, where like a lot of the pediatric JIA studies of infliximab, for example, might be 10 years old. Do they have to repeat the study for it to be valid, I guess? I mean, I've always been taught that primary literature, if it was a well-done study, is good to go. It doesn't necessarily have to be repeated. So that's what I would be going on, and I would advocate removing the 5 years.
Dr. Britton? I agree.
Might I suggest, sorry, which one of us?
You go first. Right, Laura, first, Jennifer.
I was just going to suggest, instead of the 5 years, if that's a holdup, and we have several criteria to go through today, if we could just say current, maybe that would be more lenient.
And I would second Dr. Britton's assessment on that. Thank you.
Thanks. Is there anything else on this that we've missed for discussion?
Are we adding the pediatric compendia? I can type it into the comments.
I'll take that as a motion. Luis, I'm sorry.
I was just going to mention that, yes, we're going to add to reference up here. Let's see, number 4, just direct them, if they do have an off-label use for the request, to direct them to number section 7 right away, so that they know, and then we'll make the modifications as suggested for including compendia relevant to pediatric patients as well. And then also we're open to changing the language to say to include current studies instead of capping it at 5 years.
Might say most recent relevant clinical literature.
Correct.
Something
Yeah.
like that. Okay. And are we needing approval on this with those amendments? Do I need a motion or?
Yes, please.
Okay, take a motion to approve with those amendments.
I'm happy to.
Thank you. And did I hear a second?
Second.
Thank you. All in favor of the amended motion? Aye.
Aye.
Thank you very much for that robust discussion. I hope that informs the rest of what we have to do today and we can get much of our agenda accomplished. Back to you, Luis.
Okay, thank you. Thank you so much. Now I'm going to be sharing NBREL. And okay, load this up a little bit. All right, so very similar to the previous PA form. we have criteria number 1, requiring a specialist. Number 2, we have the provider check off which diagnoses are applicable. And then number 3, we discussed about this to modify it to adding referencing to the off-label use, right?
Perfect.
Number 3, and then number 4, again, does the provider attest that the patient is not taking concurrent treatment? For part 2, for the additional criteria for ankylosing spondylitis, very similar to the previous PA form as well. And we added the 2, for number 3, we added 2 different prescription strength NSAIDs for 1 month each. Section 2, juvenile psoriatic arthritis. Is the patient at least 2 years of age or older? Does the patient have a diagnosis of mild to severe active juvenile psoriatic arthritis demonstrated by description of baseline symptoms? Oh, again, so this one we also wanted to add that those things are recorded in the chart notes so we can compare and be prepared for when they do a reauth request. Let's see. Does the board want me to go through all the criteria again as before with the previous PA form, just for completeness sake, or should I just point out?
I think let's just go through the form, describe the section, but I don't think, at least I think in the interest of time and the fact that we've had these to look at, we don't need to have you read each line.
Okay.
If that's acceptable to the board.
Thank you very much.
Thank
All
you.
right. So section 3, we have the plaque psoriasis, again, with very similar criteria as the previous form. Section 4, the polyarticular juvenile idiopathic arthritis. Again, we changed that. That needs to be documented in the chart notes, the baseline symptoms. Let's see, for psoriatic arthritis, we also emphasized for at least 3 months, have them try the DMARDs for at least 3 months, whereas it wasn't before in the previous criteria. For RA, same thing, for at least 3 months use of the initial DMARD. And then section 7, we add that we're going to amend it to be the same for all of the PA forms for off-label or compendia use. And everything else looks pretty much very similar to the last PA form.
Dr. Smith?
So I don't know if we adequately addressed the issue with the 3-month trial of DMARDs if there isn't an age indication for those DMARDs. Because now we're talking etanercept, which has even younger age indications in some cases. It doesn't make sense that they would have to go through a trial of something that doesn't have an FDA-approved indication. So maybe some language about, or suitable alternative, or just put in unless there is no age indication for these therapies, something of that nature.
Dr. Britton?
I would support that if that helps with the pediatric indications.
Thank you. I was thinking that too, with your earlier discussion, that these agents might not be appropriate. So something as, I don't know if we want to say oral alternative treatment is clinically appropriate or something like that, Louise, to identify there might be a subset of patients for whom these agents aren't ever going to be used.
Oh, I see. For example, talking about part 2 with ankylosing spondylitis. Number 3, is that what you're referring to, Dr. Smith?
No. I was looking at, for example, section 2 for juvenile psoriatic arthritis. They have to have a trial of methotrexate or leflunomide for 3 months. And certainly down to age 2, that would not be something that would be done.
I see. I understand.
So in all of those number 4s, or the last number in the section that describes the stepwise treatment, I think that might be a place to just have a general add to the end of those sentences that says, you know, as clinically appropriate or something like that. So we don't stop people from requesting something where this requirement would not be appropriate.
Yep.
Does that make sense?
Yes. Yes.
Yeah. So I think it could be just the same phrase at the end of all of those, and that would cover us. And if I have no objections well, I know that's an amendment motion again. We'll take it.
Second.
Thank you. All in favor? Aye.
Bye.
Thank you.
Aye.
Very good. Thank you so much.
Let's continue, please. Thank you.
And so, Dr. Weinstein, next, I think we have Dr. Ashley Park presenting on Humira and Otesla.
Excellent.
All right, good morning, everybody. Okay. Okay, so for the first criteria, we listed preferred and non-preferred biosimilars, and then they can check what is being requested. And number 2, is the medication being prescribed by or in consultation with the provider specializing in disease treatment. And then 3, they can check the indication of the disease, and then they can check other for the off-label. And number 4, yeah, so these criteria are pretty much similar to the previous one that Luis presented. Number 4 is asking whether they follow the FDA indication, and then similar changes will be adopted for number 4 to direct to section 7 for off-label. And number 5, does the provider attest that the patient is not taking concurrent treatment, or that the medication will not be used in combination with other immunomodulators. And so these are the disease-specific criteria. So for section 1, ankylosing spondylitis, it's a patient 18 years or older, and then have diagnosis of the disease demonstrated by the description of the baseline symptoms present in the chart notes. And then the patient tried, failed, or have contraindication to at least 2 different prescription strength NSAIDs at the maximally tolerated dose for at least 1 month each. And for section 2, Crohn's disease, is a patient at least 6 years or older. Does the patient have a diagnosis of moderate to severe active Crohn's disease as confirmed by applicable testing, such as imaging, inflammatory biomarker, disease activity scale, and then the description of the baseline symptoms, labs present in the chart notes. Section 3 for hidradenitis suppurativa, patients at least 12 years or older. Does the patient have a diagnosis of moderate to severe hidradenitis suppurativa demonstrated by the description baseline symptoms present in the chart notes. And then did the patient try fail oral tetracycline antibiotic for at least 90 days unless contraindicated? Section 4, juvenile idiopathic arthritis. The patient at least 2 years or older. Do they have moderate to severe active polyarticular juvenile idiopathic arthritis demonstrated by description of baseline symptoms present in the chart notes? And then they, if they try, fail, or have intolerance or contraindication to one NSAID or glucocorticoid for 3 months. And then the same thing for methotrexate or leflunomide for 3 months. In section 5, plaque psoriasis is a patient at least 18 years or older. And then similar thing to the previous one, disease states for criteria number 2 and 3, and then try fail at least one of these 3: methotrexate, cyclosporine, acitretin therapy. For at least 3 months, unless they're contraindicated. Psoriatic arthritis is a patient 18 years or older. And then the baseline disease symptoms described in the chart note. And then the DMARD trial failure for at least 3 months unless they're contraindicated. And then rheumatoid arthritis, is a patient 18 years or older. Do they have moderate to severe active disease described in the chart notes? And then trial failure of at least 1 DMARD for at least 3 months unless they're contraindicated. For ulcerative colitis, is a patient at least 5 years or older. And then the diagnosis of the moderate to severe disease confirmed by the applicable testings, and then description of the disease described in the chart notes. And then the trial failure of at least one of these for at least 2 months, or unless they have a contraindication. And uveitis, patient 2 years or older, and then diagnosis with the non-infectious uveitis classified as intermediate posterior or panuveitis demonstrated by this description of the baseline symptoms present in the chart notes. And then the trial failure of 1 systemic corticosteroid at the maximum indicated dose or intravitreal steroid for at least 3 months, or contraindication to all. In the section 10, we have the same language for the off-label indication, and then the similar change will be adopted for this section. And part 3 is for the non-preferred biosimilar. So they need to try fail preferred one. And then the reauthorization criteria, we require chart notes demonstrating positive clinical response. And then that was it. Okay, any questions?
Apologize, my mic. Thank you. We'll consider the form with those amendments. Luis, do we need to approve these individually as we go through? Then I would take a motion to approve the form as amended.
Yes, please.
Dr. Smith,
Yeah, I was looking at the uveitis section. And this might apply to all of them, unfortunately. Systemic corticosteroids are not always first line for uveitis, depending on whether it's like anterior or it's not. Not even intravitreal steroid. Sometimes no steroid, sometimes topical. Sorry, I can't see that. I have a Google thing on top of it.
Trial and failure of at least one systemic corticosteroid at the maximum indicated dose or intravitreal steroid for at least 3 months or contraindication to all.
Yeah, I don't know if I'd say it's a contraindication.
Right, I was thinking that language might be modified like the previous suggestion for the last bullet on each of these that says, or,
As appropriate.
yeah,
Okay, sounds good.
would that cover that?
Yeah.
Any other comments from the board? If not, we'll take a motion to approve this form as amended.
I'll motion.
I think
Second.
we motion and thank you. All in favor?
Aye.
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 All right, thank you, everybody. And then I'll be presenting Otezla. So also this one's very similar to previous ones. So it's a medication being prescribed by the provider specializing in the disease treatment, and then they can choose the disease indication, and then they can choose off-label here. And then number 3 is a question asking whether they're following the FDA indication. And yeah, we'll adopt the similar changes for this one. And number 4 is does the provider attest that the patient is not taking concurrent treatment or will not be used in combination with other immunomodulators? And then the disease-specific criteria. So for the first one, we have oral ulcers associated with Behçet's disease. The patient at least 18 years of age or older. Does the patient have the diagnosis by the description of the baseline symptoms in the chart notes? Has the patient tried failed topical steroid for at least 7 days unless tolerated or contraindicated? Has the patient failed treatment of at least one conventional immunosuppressant therapy? And then examples are listed here. And in section 2, plaque psoriasis, the patient at least 6 years or older, do they weigh at least 20 kilograms? Do they have a diagnosis of the moderate to severe disease involving 3% of the body surface area? And then for the less than 3%, they involve any like critical area listed here. And then number 5, trial failure of the one of these 3 medications for at least 3 months unless contraindicated. And the next one, psoriatic arthritis. Is the patient at least 6 years or older? Do they weigh at least 20 kilograms? Do they have the diagnosis of the active disease and then description in the chart notes? And then trial failure of at least one of the DMARD for at least 3 months unless they're contraindicated. And then section 4, we have the off-label language, and then the similar change will be adopted. And then for the reauthorization, we require chart notes demonstrating positive clinical response. Okay, any questions?
Dr. Smith?
And forgive me if I've missed it somewhere, but is there a warning on this product for exacerbation of depression.
We didn't add it here, but so we add only like black box warnings, and then Otezla doesn't have the black box warning for it, so we did not add it.
Okay, I'd always seen that warning with this particular product. I know it's not a box warning. It's in the labeling, but I don't know what people's thoughts are about that.
Board members, any suggestions about how to address that? Dr. Britton?
Just my opinion, but it's hard to cover everything in all the criteria. So having just the black box warnings there is, I think, appropriate. I think, you know, you have to give the clinician some leeway to make their determination with the member or patient.
Along those lines, I was thinking, just looking at the first criteria, these medicines are being, you know, generally utilized by people who are familiar. And I would hope that those kinds of things, you know, would be within their general practice and awareness.
That sounds good. I will point out that people with these conditions are at a high risk for depression sometimes, but I understand.
Okay, if we have some, you know, reports in the future that things are getting missed, I think we could certainly, you know, review to put an asterisk somewhere about that particular concern. And I appreciate it given the mental health issues that we're addressing currently. If there are no other comments or suggestions, I take a motion to approve the form as amended, consistent with the other forms.
Motion.
Motion. Thank you. And a second.
Second.
Not sure I heard it.
I second it. I'm not sure why my microphone's not working.
What was that? Okay, thank you. All in favor? Aye.
Aye.
Aye. Thank you.
Thank you very much.
Appreciate that so much. Now, I think we have a number of similar forms still left on the agenda. Luis, how do you think we should proceed? Oh, maybe just, well, two.
So we have 3 more forms that I think that we could possibly get through in the next 15 minutes.
Okay, with the board's indulgence, let's proceed. And I think if we just highlight those changes, I think the things are pretty consistent throughout. So let's proceed. And I appreciate everybody's cooperation.
Thank you.
Good morning. I think these next two, we're going to see a lot of similarities of some of the forms that we've already talked about. So hopefully we can just kind of go quick on these. This one is Picaiva, I believe is how it's pronounced. It's the biosimilar to the more famously known Stelara. We're going to see a lot of similar stuff of the previous one. So I'll just kind of get through it quickly so we can make sure we go over the other 3. So number 1, which medication is being requested? The Picaiva is preferred. Stikima is preferred, and then there's Stelara brand or other biosimilars. Number 2 is the same language as other forms regarding specialist prescriber. Number 3 includes the diagnosis that these medications are indicated for. Number 4 is similar to other ones. It's requested medication, follow FDA approved indications, etc. Number 5, provider attests no concurrent TNF inhibitor or other medications. Very, I think, same exact language as in some of the other forms we've seen. And then number 6, I think, is unique to this one compared to some of the other ones. It says, has the patient tried and failed, had an intolerance to, or had a contraindication to the preferred TNF, if applicable. Part 2 is going to be very similar to the other ones, where it breaks down every indication. So section 1 is Crohn's disease, 18 years or older. Does the patient have a diagnosis of moderate to severe Crohn's as confirmed by applicable testing? So getting baseline information there. Section 2 is for plaque psoriasis, age 6 or older, moderate to severe plaque psoriasis, greater than 3% of body surface area. If less than 3%, is it in a sensitive area, such as scalp, palmar, foot, or groin involvement, causing significant disability? Number 4 is the tried failure of one of these medications for at least 3 months, methotrexate, cyclosporin, acitretin therapy. Section 3 for psoriatic arthritis, age 6 or older. Description of the baseline circumstance for the patient regarding their psoriatic arthritis, and then a trial failure of at least 1 DMARD for at least 3 months. Section 4 is for ulcerative colitis, 18 years or older. Baseline diagnosis is confirmed by diagnostic imaging, biomarkers, etc. And then a trial and failure of 1 of the following medications for at least 2 months. And then section 5 is the same off-label section we've seen in all the other ones. Part 3 is for the non-preferred medications in this, and reauthorization criteria, same that we've seen. So a lot of very similar things we've seen in other ones, just specific to the indications. Hope I didn't go too quick there, but does anyone have any questions on this one?
Thank you very much. I think we're seeing the repeated language and the same amendments would be considered. Any other comments or suggestions from the board? If not, I'll take a motion to approve the form as amended, consistent with the other forms.
I'll motion.
Thank you. Do we have a second?
Second.
Thank you. All in favor?
Aye.
Aye.
Thank you. Next up.
All right,
Who's-
next up
Here.
is HALT.
Thank you.
And again, we're going to see some similar things here. This is only 1 medication. Yeah, I think it might be shorter, but anyway, just going through it. Number 1, same as what we've been seeing, prescribed by or in consultation with a specialist. Number 2 is marking the diagnosis. Number 3 is the same we've seen, no concurrent other biologic, TNF inhibitor, or DMARDs, etc. Number 4, does it align with the FDA-approved indications, age, dosing, etc. Number 5, has the patient tried and failed, demonstrated intolerance to or contraindicated to the preferred TNF, if applicable. Part 2, section 1 is for ankylosing spondylitis, 18 years or older. And then is the diagnosis of ankylosing spondylitis demonstrated, or gosh, I'm going too fast now. Is there a description of the baseline symptoms present in the chart notes? Section 2 is for non-radiographic axial spondyloarthritis. Number 1, 18 years or older. Number 2, does the patient have the diagnosis with objective signs of inflammation? Number 3, plaque psoriasis. Is the patient at least 6 or older? Has the patient been diagnosed with moderate to severe, involving at least 3% body surface area? Or if it's, and number 3, if it's less than 3%, is a higher risk body area involved? Section 4 for psoriatic arthritis, 18 years or older. Baseline description in the chart notes. And then Section 5 is the same off-label section that we will be adjusting for other ones. And then the same reauthorization criteria we've seen in other ones. So that's it for Taltz. Does anyone have any questions on this one?
I thank you. Are there additional suggestions, comments from the board? If not, we'll take a motion to approve. Oh, Dr. Brisson?
Sorry, I was just trying to find the section where this was applicable. The note from my team says Taltz does not have a DMARD step therapy for psoriatic arthritis and psoriasis. Just had the question about that.
Yeah, go up a little bit. It's yeah. To above in the form, I think we put the standard paragraph in. There we go. Number 3. Is that what you're looking for? Where it says, lists out the different alternative therapies.
I think they were just asking if Taltz has the same step as ustekinumab. To have to go through DMARDs.
I think the only step we have is part 1, number 5, with the preferred TNF, if applicable.
Yeah.
But otherwise, did you say psoriatic arthritis? I'm sorry.
Yeah, so psoriasis and psoriatic arthritis. Those two
Yeah, otherwise we
conditions.
don't have a step therapy required.
I can answer that, Skylar.
Sure.
So yes, so most of these criteria is similar to the other forms. However, due to some limitations in the language that we can imply, due to the agreement that we have with the manufacturers, and limitations of what we can put on here, but those step through will be similar and treated similar to the form, in the sense that requiring a step through of a TNF.
Gotcha. Thank you.
That's satisfactory.
Yeah, I understand that. So with that, I'll make a motion to approve.
I appreciate that. Second to approve the form as amended.
Okay.
Thank you. All in favor? Aye.
Aye.
Thank you for that. I know with the specificities of each of these diseases and the range of treatments, it does get a little complex to make the form clear, but you've all done a tremendous amount of work on this, and I think we're making good progress. Next, we've got Thinker. Just a discussion of the non-preferred immunomodulators.
Yes. Okay, so this is just a general form for all of our non-preferred immunomodulators. The first one says the patient have a documented diagnosis of a condition listed on the medication's FDA approved label, and then condition, and also other confirmation tests if applicable. Is the medication being prescribed by or in consultation with a provider specializing in the disease treatment? Does the use of the medication follow FDA approved label use instruction, including age, dose, monitoring for box warnings and contraindications? And again, we'll apply the off-label language. Has the provider submitted documentation of appropriate first-line treatments or interventions if current treatment centers recommend other treatments prior to use of the requested drug? Has the patient tried and failed at least 2 preferred products in the immunomodulator therapeutic class for a minimum of 3 months, or has the prescriber demonstrated medical necessity for a non-preferred product, if applicable? Does the provider attest that the patient is not on current treatment or that the medication will not be used in combination with other TNF inhibitor, biologic response modifier, or other biologic DMARDs, JAK inhibitors, or PDE4 inhibitors, as verified by prescriber attestation, patient's med field history, or submitted documentation? And then we have the same off-label language again with also the same modifier. And then we did have a note that the patient must have regular appointments to receive or follow up the medication in the provider's office. The patient must remain in the office for an adequate amount of time to allow for observation or term for anaphylaxis if necessary. If and when any change of dose is requested, the prescriber must indicate in writing the reasoning for the dose increase. Sorry, I kind of went over that really quickly, but if there's any questions or concerns.
Thank you. Dr. Britton?
Just one question. The team wanted to know on number 5, if there was a reason for 2, or if you wanted to have them try all the preferred so that we can adhere to the PDL more strictly? Or is that language that we have to keep?
I believe in discussion with the ACOs, it was consistent with all the other payers that would try at least 2 preferred products. That's kind of standard.
Okay. This is coming from 2 out of the 4, but it's fine. I don't think it's that big of a deal. Thank you.
That would be a minimum, right? At least 2. There might be more. Okay. I'm sure there are many considerations you all are keeping in mind that go a little beyond my clinical expertise here, as well as the procedural aspect. So I very much appreciate the input. Any other comments or suggestions from the board members? This gets us to a kind of a generic form for folks to use, where we've identified any of the language modifications that would make this consistent with the PAs for the identified products. I would take a motion to approve the form as amended.
So moved.
Thank you. Do I have a second?
This is Dr. Siegfried. I second.
Thank you so much. We missed seeing you today. All in favor?
Aye.
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 Thank you.
Very much. As a tremendous amount of work, and I appreciate everybody's attention to the details involved here. Our next meeting is for December the 11th, of some new prior auths. And if there's no further discussion or comments, I would thank the board, wish you a wonderful Thanksgiving holiday, and ask for a motion to adjourn.
So moved.
Thank you. And a couple seconds too as well. Thank you so much, everyone. Have a wonderful day.
Thank you.
Bye.
Bye, everybody.
Thank you.
Thank you.